Welcome to our panel on Integrity Icon Health Sector. We have several specialists here with us from our different editions of Integrity Icon from different countries as well. We're very lucky to have them here. There is one panel, before we start completely, there's one panelist from Mexico, Doctora Mónica Armas, who speaks in Spanish. We're gonna have simultaneous translation from her from Spanish to English, as well as subtitles. For this to happen, in the lower menu on Zoom, you're gonna find a globe that says interpretation. In there, you can select the option from English, where you'll be able to hear what she's saying in English, thanks to our colleague Ingrid Lowenberg from Mexico City. If you also need subtitles, Alawi is going to be executing those. To activate the subtitles, you have to go to the More menu on Zoom, which is the 3 dots menu. And in there, you're going to find the subtitles options. For any further questions in this, I'm going to ask you to please direct your questions in the chat to Alawi or Ingrid or me. I ask you to be patient regarding this matter. It might be tricky to set up initially, but trust me, it works wonderful when you do. Now, we're going to start now. We have here with us 5 panelists. Rumbitsai Primrose from Zimbabwe, Faith Mormon from Nigeria, Mónica Armas Agoya from Mexico, the Dr. Ruth Abaya from Philadelphia,
myself, I will grab a small
and the Dr. Anna Cross from South Africa. I'm going to ask you to kindly mute yourselves when you get in the room, please, so that you don't interfere with the recording. And Dr. Anna Cross from South Africa. So we're going to start with a brief introduction from each one of the participants. I'm going to need you to introduce yourselves, and then we will get started with the general questions to get the dialogue going. Rumbitsai Primrose, if you could please introduce yourself to the room. Thank you. Hello, Rumbitsai Primrose. Are you available to introduce yourself to the room, please?
It looks like she's having network issues right now. She's joining in.
Okay, so let's start with Faith Momo, please. Hello.
Hello. I am Faith Momo.
Can you introduce yourself and give us a brief background on what you do, please?
Oh, my name is Faith Momo. I am from Nigeria. I work with the local government in Ofu, Kogi State, a focal person to various health programs. I won 2020 Accountability Lab Icon. Thank you.
Thank you so much. Mónica Armas, can you, te puedes presentar con la sala, por favor? Can you introduce yourself?
Yeah.
Mónica, te puedes presentar, por favor?
Hola, ¿cómo soy? Soy secretaria de Información de la Secretaría de Salud de Zacatecas, México. Participé en Integrity Icons en el pasado. Es un gusto estar aquí con ustedes.
Thank you so much. Dr. Ruth Abaya, please, can you introduce yourself to the panel?
Sure. Good morning, everyone. It's good to be here. My name is Ruth Abaya. I'm a pediatric ER physician in Philadelphia. Worked with the health department here in Philadelphia on violence prevention work, which is how I first intersected with the accountability lab. I'm currently Senior Director for Health Systems and CVI Integration with the Health Alliance for Violence Intervention, which works on violence intervention in hospital settings. And I have to say, I'm delighted to see my fellow countrymen from Nigeria. I'm originally from Nigeria and from Kogi State specifically. So very good to see you all.
Kogi State.
Amazing. Thank you so much. And now finally, last but not least, we have Dr. Anna Cross from South Africa. If you could introduce yourself, please.
Hi, I'm Anna Cross. I'm from Cape Town, South Africa. I work in primary care. I've spent about a decade and a bit working in indigent communities, mostly HIV and TB related care. Yeah, so that's how I ended up here.
Thank you so much. So you have met our panelists now. We're gonna start with a round of questions so that we can get the conversation going. I'll be directing the questions initially, so directly to the participants so we can get the conversation going, but then we'll have some open dialogue discussions. First of all, this question, let's start with Dr. Faith Momo. In your what do you think health workers in your country need to have better accountability in the sector? Let's start with Faith, please.
Come again, sir?
Yes, I'm asking, what do you think health workers in your country need to have better accountability in the sector?
Okay. Accountability in the health sector is of paramount importance due to several compelling reasons. Number one, patient safety. Accountability ensures that healthcare professionals and institutions adhere to established standards and protocols, minimizing the risk of errors, adverse events, and patient harm when healthcare providers are held accountable for their actions. They are more likely to prioritize patient safety in their decision, making and practice. Number two, quality of care. Holding healthcare professionals accountable promotes the delivery of high quality care by setting clear expectations and of standards. Accountability encourages continuous improvements in medical practices, treatments, and technologies, resulting in better outcomes for patients. Number three is trust and confidence. Patients and their families places their trust in healthcare providers and systems. When accountability is upheld, this trust is reinforced. Patients feel confident that their well-being is the top priority, leading to better patient-providers relationship and increased patient satisfaction. Thank you.
Thank you so much. Ruth, would you like to continue?
Sure. So my career has taken me kind of out of the clinical setting. I still do clinical work, but I also work in public health. And so I'm going to speak a little bit to the importance of accountability when healthcare providers are crossing sectors and interacting in interdisciplinary efforts around a core public health crisis such as violence. So I think accountability is important because it's impossible to make headway if you don't have the trust of the people who are most affected by the public health problem you're addressing. And so when it comes to violence in the United States of America, there are deep racial disparities in how specifically community violence plays out. And there are deep trust issues in the sectors that have been traditionally tasked with dealing with this problem, specifically the criminal justice sector. So when health emerges as a leader in that space, if the health sector and the practitioners there don't have the trust of those most affected by violence, communities most affected by violence, the public health measures that are being enacted are not going to be successful because they're dependent upon community trust. I think that's true for a number of public health crises. And so if we look at COVID as kind of a parallel crisis in the United States that surged at the same time, or surged as violence was surging, trust was a huge part. Trust specifically in the health sector was a huge part of implementing adequate protections, vaccine protocols, mask mandates, et cetera. So trust is integral to what we do. Our patients trust us with extremely personal information. They trust us with their health. They trust us with their life and the life of their loved ones. They do that because our sector has built a reputation. If we're not accountable externally and internally, we're not going to be able to hold on to that trust. And anything we suggest, regardless of how scientifically sound it is not going to be successfully enacted. So I think that's the core reason from my perspective.
Thank you so much, Ruth. Doctora Monica, would you kindly like to answer the question? What do you think health workers in your country need to have better accountability in the sector? Thank you.
Bueno, sobre la importancia o desarrollo de las estructuras que tenemos en salud en México, creo que hay tres condiciones importantes con respecto a la salud pública que hemos tenido. En la condición de la emergencia que se vive con COVID, las condiciones de la elevación de la tasa de las enfermedades crónico-degenerativas y su letalidad, y también el avance que necesitamos retomar en México con respecto a la implementación del e-health, de las tecnologías a través de la telemedicina para poder cubrir la parte de la cobertura universal de la prestación de servicios de salud. Creo que dentro de las condicionantes o las situaciones que tenemos que ver y de las estrategias que realizamos nosotros, está precisamente en cómo a través del uso de las tecnologías podemos favorecer acceso a la prestación de servicios a usuarios, en este caso de mi estado y de mi país.
Muchas gracias, Monica. Thank you so much. Anna, would you like to answer the question now, please? Thank you. Dr. Anna Cross, what do you think health workers in your country need to have better accountability in the sector? Dr. Anna Cross, what do you think health workers in your country need to have better accountability in the sector?
So I'm just going to give a bit of background about how the health sector works in South Africa. So basically in South Africa, we have public health sector that is free, or it's means tested actually. But basically in primary care, there's no way to pay for services. So essentially primary health care is free for indigent people in South Africa. And then the more affluent people have private medical care. So, and they don't have to use the public sector. So the public sector in South Africa caters for the most vulnerable populations, including immigrant populations. So for accountability, one of the most important and crucial things is the best use of scarce resources, because the healthcare in primary care in public sector is free. It's essentially, it's government funded. So the resources are limited because we're not a wealthy country. And so we have to ensure best use of limited resources. What helps with that is good, clear, evidence-based clinical guidelines, so that everybody kind of gets the same level of care and it's good care. And so that you also know that what you're doing is right. And what's also very important is interdisciplinary collaboration. So I need to know that I can ask a nurse, or I can ask a senior doctor for help if I need it, and they can do the same of me. And then going back to what Dr. Ruth said about trust, public health measures require community buy-in. And so if they don't trust that what we're providing is good care, and they don't trust us, then public health measures will fail. And you know, we have the biggest HIV treatment program in the world, and also Cape Town is the capital of TB in the world. So we have really big public health problems here that require community buy-in and therefore accountability.
Thank you so much. It's been really interesting to start finding the common threads in accountability globally. For those of you that missed what Dr. Monica said, she was speaking specifically about the same thing, about that it's important to facilitate resources to move along primary care, especially in far removed communities. Dr. Monica, for instance, is a specialist in telemedicine, which is a huge component of the accessibility of medical services to traditionally marginalized and remote communities in Mexico. And so strengthening the presence in the sector by having the sensibility to provide these technical tools and access is also trust building exercise, especially when communities are not native Spanish speakers. Which is, I think, an interesting component and challenge as well for many practitioners that work in the field. So we're going to bring us to questions. We're going to stay with this. Do you have a role in improving the sector? Why yes or why not? Thank you. Faith Momo, I'm going to ask you this question again. Do you feel like you have a role in improving the health sector? Why yes or why not? Faith.
Bueno, es que no me llega la atención de...
No, I'm asking.
¿Puedes repetirme la pregunta en español?
Perdón, Mónica, le estoy preguntando a otro panelista en este momento.
Ah, okay.
Faith, are you available? You're on mute, Faith.
Mute.
You're on mute, yes. Please, do you feel like you have a role in improving the health sector? Why or why not?
I have a role. Yes, I have a role in improving the health sector.
Can you expand, please? Why yes, why not?
Yes, I have a role because I had series of experience in my 21 years of service in the health sector. Going through my profile, which earned me my admiration before followers and colleagues in office. So yes, both the good and bad experience. For you to be upright and ensure corruption in workplace, particularly in health sector, it requires a lot of sacrifice. As a person, because of what I believe in, that is why I say I have a role to play. The role I have to play is to stand upright, to stand against all odds, to make sure that the work is done properly. The resources go to where it's supposed to go. It's a good thing to be known for what is right than engaging in corrupt practices. In my office, there are lots of things that is happening there. I stood and said no to it. There are lots of people that started attacking me here and there, that they have been doing it before my arrival, that they will still continue. The money that is coming is not going to where it's supposed to go, because all this money is going to the villages. The drugs are going to the villages. All the palliatives are going to the villages. But everything will be diverted to another corner. But as few individuals who pack everything and use it for their own personal gain. But I stood and said no to it. And since I received that award, the award now pushes me forward, causes me to stand, because many eyes are on me. And I continue to say no to it. Today, in my office, wherever anything of such enter, if it's money or food items, drugs to pregnant mothers, to children, when they enter our office today, there is nothing like diverting it to another corner again. When I appear, they will be afraid. Not that I'm carrying gun on anything. They're afraid that maybe I'll say something, I'll report them to somebody, that they will be arrested. So because of that, many started calling me. Anytime they're having such problem, having problem of corruption here and there, they'll call me and ask for advice. What am I going to do? How am I going to solve this problem? Then I'll tell them this: you stand your ground and say no to it. Because poverty rate in our area is very high. The money we are receiving is not much. We are not receiving the money we're supposed to receive. We are receiving percentage salaries. So that pushes people to do all sorts of things to make money. But I continue with them. I continue to advise them, and they follow my footsteps. Today, a lot of changes. Not that everything will be okay, but there are lots of changes. There is an improvement, great improvement in my office, even in the local government. Thank you.
Thanks so much, Faith. Ruth, I'm sorry. Ruth, we're gonna go with you. Do you feel like you have a role in improving the health sector? Why or why not? Thank you.
Yeah, so I would agree with Faith that definitely I feel that I have a role, and I feel that everyone has a role. So I think one way to phrase it is to say that a single participant in health sector work, a single member of a health system, can contaminate the trust we were just talking about and plant seeds of distrust and corruption and misuse. And that becomes, I think, contagious. Similarly, a single person can build trust for a single patient interacting with the system, and facilitate a culture of responsibility. So I don't think there's anyone who's working in that sector who doesn't have a role in demonstrating all of the things that have been outlined so far: responsible use of resources, care, true care for the patient in front of you, attentiveness, responsibility, timeliness, racial justice. Those interactions begin with the person who checks a patient in at the front desk, right? And that trust can be lost there. And that cascades into the rest of the medical visit and into the rest of that person's, frankly, lifelong perspective on the health sector and their ability to trust those who are entrusted with their health. So if you're in the health sector in any capacity, I think you have a responsibility to be accountable to your peers and to your colleagues in the work that you do.
Thank you so much. Mónica, vamos contigo. Mónica, we're going with you now. La pregunta es, ¿crees que tienes algún rol activo? ¿Cuál crees que es tu rol activo en mejorar el sector salud?
Hola, no. El papel que juego en general dentro de la estructura de la Secretaría de Salud de Zacatecas es un rol muy importante. Tiene que ver con la integridad porque manejamos la parte de la información clínica del paciente a través de los reservorios de expediente clínico y, por ejemplo, la primera parte que yo tengo que guardar y cuidar es la integridad de los datos que otorga el paciente y la integridad de la información que otorga el médico. También dentro de los roles que tenemos que cuidar es sobre la acción de la productividad, el análisis de la morbilidad real, porque tenemos que transparentar los logros, señalar, se tienen que atacar oportunidades para la mejora en la prestación de servicios. En el rol que juego como auditora de la edad materna, de la mortalidad infantil, todavía considero servicios de estrictamente más duros, porque mis intervenciones tienen que señalar dónde se encuentran las debilidades en la prestación de servicios de salud y que se tienen que mejorar para evitar que de manera posterior fallezcan las mujeres y niños. El rol que juego es muy importante y justamente resguardo de la honestidad. Señor, bien la consideración de la oportunidad y la calidad en la prestación de servicios como la aleatoriedad en la salud.
Muchas gracias, Mónica. To the panel, paraphrasing, Dr. Monica mentioned that for her, the key aspect where she can influence the most public policy in Mexico is by having a 360 integral practice into developing communities, because it's not only about the primary contact for the communities where she's inserting as well. She has to make sure that the ethics committee in the telehealth practice in Mexico has a well-structured the depository of information, because there are several problems that relate to violence at different levels with regards to the relationship to doctor-patient, particularly with vulnerable populations.
The video muted.
By practicing telemedicine in Mexico, are well integrated and that they are accessible to the doctors. The relationship between the patient and the doctor is going to be better structured, but also they're going to do better analysis, understanding where the mortality rates and why are they happening, so that they can address those problems directly and also avoid corruption. But it's also like full traceability of the accountability issue in the relationship between the patient and the doctor, at least for telemedicine in Mexico. Moving along, Dr. Anna Cross, what do you feel like you have a role in improving the health sector? Why or why not?
So yes, I feel I have a role, but I also feel that the role has limitations. So as has been previously said, you've got to build trusting relationships with the patients in front of you, and that spills over into trusting relationships with the community. And part of that is listening to what the patients actually have to say. A lot of patients' feedback I get from patients is that the doctors they see don't listen. So sometimes you just need to actually take the time and hear what they are saying, and then providing the best care that I can, and doing what is right for the patient. So even if it's not what is supposed to be done for the patient, sometimes what is right for the patient, you have to go against what other people would do. And in doing so, you have to be brave, and you have to be an example to your colleagues and those around you. but as I said, it's limited because as a clinician, you're a small cog in a big machine, especially in South Africa where you're working in a public health system. There's a lot of politics and a lot of red tape. You're actually not allowed to speak to the media to criticize. If you do, you can be fired. So really your hands are kind of tied, but it doesn't stop me from trying to implement or point out weaknesses and point out areas where we could improve things and try and implement better ways of doing things and more cost-effective ways of doing things. So we definitely do have a role, but it's not, as a clinician, it's kind of limited.
Thank you so much, Anna. We're moving into our last question for the panel. Let's see. What do you think accountability is important in the health sector? Let's start with Dr. Faith Momo. Dr. Faith?
Okay. Come again.
Dr. Faith, why do you think what is the biggest accountability? Why do you think accountability is really important in the sector? What is the biggest stake on accountability in the sector?
Network. Season. Season.
Hello, Dr. Faith. Why is accountability important in the healthcare sector in Nigeria? Can you hear me?
It's cracking. It's cracking.
Okay,
So,
I'm going to speak
okay.
slowly. Why do you think accountability is important in the healthcare sector in Nigeria?
Okay.
Can you hear me, Doctor?
The network is
Okay.
frustrating.
Why is accountability important in Nigeria? Okay, let's move on while we fix the issue with Faith. Ruth, can you tell us why is accountability important in the sector in Philadelphia, please?
I think for the same reason that accountability is important anywhere. I think that we operate in a society where nothing functions well if we're unaccountable to anybody, if we aren't held to a standard, and if that standard isn't kind of maintained by people external to us. I think it's important to be humble enough to recognize that none of us are going to do a perfect job at what we do and are going to even see the ways in which our behavior might affect other people without the eyes of our neighbor. And so the ability to build a sector that has the eyes of our colleagues on us and provides a safe space for our colleagues to speak into our work and for us to speak into their work, just has the greatest chance of success in actually protecting patients going forward. I also think that in particular, we're talking about health. We're talking about, in some cases, life and death. Dr. Cross was talking about the highest, numbers of HIV and TB patients in the world. This is a time where there are a lot of concurrent public health crises of various types around the world. And so if if trust in the health sector takes a hit right now, we are not well poised for the next global pandemic, for resurgences of these kind of chronic public health issues. We can't face them because we don't have the trust of the people we need to treat. So I just really want to reiterate that we're always going to need the trust of our patients. We're always going to need the trust of our colleagues. And so building a system that requires some level of accountability horizontally and vertically within the health sector is of critical importance.
Thank you so much, Ruth. Mónica, vamos contigo. ¿Por qué crees que la responsabilidad y la accountability es importante en el sector, en el sector de salud pública en México?
Hola. Bueno, creo que en México tenemos mucho que avanzar en la parte de la transparencia y la integralidad en salud. Lo que vivimos en este proceso de este periodo de sistema de salud en esta etapa gubernamental en México, y creo que una parte también hay que comentarlo en el sentido de América Latina. El sistema de salud tiene le ha quedado a deber a la sociedad muchas cosas. Por ejemplo, no sé si suceda en África, en Europa, en condiciones, ¿no? Por ejemplo, lo que comenta Ana, lo que comenta Ruth, pero por ejemplo en México no tenemos claro el acerca de la mortalidad y con respecto a la situación epidemiológica de COVID. No hemos avanzado en conocer, por ejemplo, cuál es realmente la estrategia para atención a las personas, en este caso específicamente a la población infantil con cáncer. No hemos avanzado en la política pública con respecto a la transparencia, de la adquisición de medicamentos, de la infraestructura, del equipamiento moderno que requiere ya en este caso específicamente hablando de mi país, para la prestación de servicios, después de un retraso, una falta de atención a los pacientes, por ejemplo, en un periodo de 3 años de padecimientos crónico-degenerativos. Todavía tenemos atrasos en la atención a la mujer embarazada en las regiones del sur de nuestro país. O sea, la tasa de mortalidad infantil en este caso la mortalidad de razón materna en México está en condición importante por la falta de acceso a los servicios de salud. Entonces, en nuestro continente, o sea, porque también, pues bueno, tenemos la referencia de lo que está viviendo el sistema de salud, por ejemplo, el de Argentina, escuchamos también lo que vive, por ejemplo, hablando en mi continente, la falta de acceso a la salud que tiene la gente que está en Estados Unidos, ¿no? Y que muchos son migrantes mexicanos y que no tienen salud. Entonces, creo que en general la visión universal hacia la búsqueda de la transparencia, la integridad y la mejora de los servicios de salud y los sistemas de salud dentro de los países, dentro de los continentes, en un periodo de un lustro, quiero hacerlo muy corto, tiene mucha deuda con su sociedad. Por ejemplo, no hemos avanzado en el caso de México con la medicina intercultural que comentaba hace un rato Ruth. no hemos avanzado sobre el reconocimiento, por ejemplo, de lo que es los avances en las políticas de prevención de violencia de género, ¿no? Y nuestro país ahorita vive una condición que desafortunadamente tiene que ver también con condiciones de adicciones de salud mental. Entonces, creo que el sistema, los sistemas generales del mundo, esté viendo a su sociedad todavía en la prestación de servicios, en la cobertura y la realización.
Gracias, Monica. Thank you so much. Paraphrasing Doctora Monica, she considers 5 integral axes of inclusion and integrity for improving accountability in Mexico. There's a key role to work with different topics of intercultural medicine to have correct mechanisms for transparency and integrating and understand mortality based on different aspects, but mainly from the COVID pandemic. We still don't have the necessary data to assess the impact of the pandemic in Mexico. As well as the 2 essential topics of gender violence in Mexico, which has been receding in the past few years, and integrating immigrant communities to the healthcare sector, because Mexico is a high transit country. Not only it provides local immigration, but it's also a high transit country for other countries in the region, population from other countries in the region that pass on their way to the US and oftentimes end up being living in the country because of the immigration policies. Those populations are not properly integrated into the healthcare sector. Moving forward, Dr. Ana Cross, can you talk us about your perspective of accountability in the sector?
Can you clarify the question again, David?
Yes, sorry. Can you tell us about what do you think the main role for accountability in the sector in South Africa is right now?
Well, the role of accountability in the sector is kind of like, what we've spoken of already is trying to mitigate the impact of public health crises, such as HIV and TB and COVID more recently, and also on a common thread, gender-based violence, which is a massive problem in South Africa. So we need to be accountable to ourselves and to each other. And one of the things in clinical medicine that helps one do that is mortality and morbidity meetings, which really should, in a clinical setting, be held routinely, so that you can see where you went wrong and where you can improve. But we as clinicians and as the face of healthcare need to be well informed so that we can dispel myths, especially, almost everyone knows the story of the HIV pandemic in South Africa and our former president who said HIV doesn't cause AIDS. And, we had to be the face of HIV. And, it was also, in those days, it was having sex with a virgin will cure your AIDS. In those days, those were the myths that we were having to dispel. And more recently with COVID, the vaccine myths that we had to try and dispel. So we need to be really well informed to be able to inform our patients and therefore the communities around us. So we have to be accountable for public health at work, but also at home, so that we can inform our friends and families and spread the word into our local communities where we live, not only where we work. It's critical to public health, actually, just generally, to be accountable.
Thank you so much. I agree. I see here within the answers that there is a common thread as well that emerging about transparency and information access that's critical to assessing programs' effectiveness and also to mitigate corruption. If you can build upon, staying with you, Dr. Ana, if you can build upon a little bit on that, what do you think, how do you balance the need for transparency, but also with the privacy concerns for patients and healthcare providers, especially given the fact that in some cases in developing countries, this can lead directly into direct discrimination in case there are privacy breaches. Can you expand a little? What is your perspective on this?
Well, I mean, the way it works in South Africa, we're very separate to the politics as clinicians. So if you have an issue to raise, you would raise it in a general sense. So there's not necessarily privacy issues at stake. Yeah, I'm not quite sure like how to answer this question. It's more, for me, it's more when there are accountability issues, it's the clinicians who don't want to speak up because they're afraid. It's not the patients necessarily who are going to suffer. It's the patients don't want to raise complaints because they feel that they will be targeted. So they may not necessarily want to raise their own complaints in a general forum. They will raise it to us as clinicians. And then as clinicians are afraid to speak out. So that's why one has to be brave, like I said before. One has to be the one to stick one's neck out. Yeah, but there's no necessarily breach of patient confidentiality in that.
Okay, thank you so much. Dr. Ruth, what's your perspective on this topic between the relationship between transparency and information access, but also the rights to privacy from critical patients in the healthcare sector?
Yeah, this is a really timely issue in the field of violence prevention, because I think that it's important to coordinate efforts. It's important for violence prevention practitioners in various sectors, going from community organizations to the hospital setting and elsewhere, are integrated in their efforts. That is definitely standard of care for the patient, right? That everybody knows what everybody else is doing, the right hand knows what the left hand is doing, and there's integration of efforts. That requires some level of data sharing, right? And that is something that's standard within a hospital, right? The endocrinologist will share information with the nephrologist, will share information with the cardiologist. We're all talking about the same patient, we're all looking at the same numbers. But sharing that outside of hospital walls, especially when it comes to really fraught issues like violence, is complicated. Because as we've been saying ad nauseum, trust is incredibly important. And when you're sharing a patient's information, you risk breaching their trust. But if you're sharing it for the purposes of giving them access to prevention resources or treatment, that I think is standard of care in medicine. And so what we've been trying to do in my field is bringing violence into the health sector. It hasn't traditionally been there. That's not where people have seen most of the solutions. But if we bring it into the healthcare sector, healthcare is very facile with sharing information securely and maintaining trust while we do it, with all of the consultants and practitioners that we need to care for the patient. We are used to doing that. We know how to do that safely, and we need to be able to integrate and kind of build that same model outside of hospital walls for public health issues, because no health issue stays within hospital walls, right? We always have to be working with partners on the ground. So how do you share that information? When it comes to there's another element of transparency that I think I heard others alluding to around being transparent around what we're doing. So transparency is also about internal transparency. So in our hospital, we've recently started tracking metrics like how many people who get immediate treatment for their pain crisis, who are coming in with sickle cell disease, right? What is the time to pain treatment compared to other conditions that also are associated with pain? Because we know that sickle cell disease affects Black and Brown individuals more, and we know that other causes of pain have a more wide range of kind of people who have pain due to, for example, a fracture. Are we slower to give pain meds to Black patients is the question we're asking ourselves. And it's an internal question that we're tracking and reporting back to ourselves for the purposes of transparency and accountability. I think it's very important for any health system to track those kinds of metrics, to be transparent about how well we're performing. If there's a standard of care, time to antibiotics, right? Duration of treatment, we need to track how we're doing on those metrics and be internally responsible around reporting those metrics back to our own staff. And then I think we also have to think about being externally accountable. So do we have a public dashboard where we say transparently, this is how we're doing in meeting this established standard of care? And we're doing better in this population than in that population, because if that information is public, if we're transparent about those performance measures, I think we all do better. So there's transparency and data sharing, but there's also transparency around kind of aggregate metrics. Are we collectively doing the thing that we say we're trying to do? And I think Dr. Momo was making reference to kind of having to fight for that, right? Like people pushing to keep some of that information quiet, or to not be transparent about how resources are being used, or how we're deploying what we have, and whether or not we're meeting standards. But if we have to report it, even just internally, I think that changes behavior. I'm forgetting the term for this psychological phenomenon by which we all act better when we think we're being watched. It's just human nature, and I think we need to be cognizant of that in how we build these reporting, internal and external reporting structures.
Thank you so much, Ruth. I think this is going to be an interesting conversation. Going now to Mónica. Mónica, considerando las intervenciones de los demás participantes, Mónica, considering the interventions from other participants, ¿cuál crees que sea el principal reto entre la transparencia y el acceso a la información de los pacientes, pero también el respeto al derecho de la privacidad de los pacientes? The respect to right to privacy of patients and the relationship in transparency.
Pues fíjense que escucho mucho la parte de la conversación o los comentarios de Ana y de Ruth, y hay muchas coincidencias también con lo que vivimos en América Latina y en especial en México. México ha tenido avances en materia de cuidado y el resguardo de la información a partir de la creación de la ley de acceso a la información, y se genera una estructura que se llama de usar, que le otorga en este caso al usuario, al paciente, la autoridad sobre sus datos. Esta ley en transversalización digamos en este caso, de los sistemas de información en salud, que tiene dos ejes vertientes: la parte de los avances que tenemos en la teleradiología y en el expediente clínico electrónico. ¿Qué nos permite en este proceso, en algo que digamos es muy asertivo o fue muy asertivo y muy bueno en México, que el usuario sea precisamente el dueño del dato? ¿Qué obliga a qué obliga este tipo de leyes, en el caso de México, a las instituciones a garantizar precisamente la seguridad de la información, ¿no? Que no vaya a existir modificación de los datos en el expediente clínico electrónico, y eso que nos obliga a la adquisición de software o desarrollos de sistemas informáticos muy seguros que permitan de alguna manera precisamente otorgarle, en este caso, a los usuarios, a los pacientes, su información. ¿Hacia dónde tiene que ir México, o hacia dónde puede, por ejemplo, en este caso, tiene que ir la meta del Estado, por ejemplo, de Zacatecas, a la consolidación de la ley del expediente clínico para la universalización del dato? O sea, que de alguna manera el dato que tenemos en el expediente clínico sea transversal en el mismo sistema de salud. Y esa es una parte en la que se ha avanzado. Con respecto a otra parte de la información, que es la evaluación que comentaba Ruth, que se tiene que avanzar. En México, en el sexenio antepasado, se desarrolla el Sistema Nacional de Calidad. Y entonces este sistema tenía como objeto precisamente conocer cuál era la percepción del usuario entre la prestación de servicios, en tres ejes muy importantes: en la eficiencia y la calidad en la prestación de servicios. O sea, qué tan eficiente era la atención que recibían en sus clínicas o en sus hospitales, sus centros de salud, sus hospitales. Lo otro era la parte del surtimiento de medicamentos, o sea, cuánto era el medicamento al paciente. Y lo siguiente era cómo veía el usuario la infraestructura de salud donde él acudía a su atención. Desafortunadamente, este sistema, con el paso de los años, se ha vuelto corruptible, porque de momento en el país, y lo comento con mucha seguridad, observamos que el usuario dicen: es que no me surten medicamentos, no tengo atención oportuna, porque voy a esperar, no sé, 2 o 3 horas para poder atender. La calidad con la que el médico me atendió, no me explicó, no me dijo cuál era mi padecimiento, contrasta mucho con lo que observamos de repente en las plataformas de información de la Secretaría de Salud, ¿no? Entonces, en ese sentido, se tiene que trabajar mucho en cuidar dentro de nuestro país la confiabilidad del, ¿no? La seguridad, la integridad, perdón, les digo mucho a la gente que trabaja conmigo, la integridad del dato, proporcionar y que sea coincidente el dato que nosotros tenemos con lo que la población, o sea, está percibiendo, que esa es una parte que ahora nuestro país, o sea, no tiene, ¿no? Los usuarios, el gobierno dice, no, es que sí tengo esto, o bueno, digo que yo soy una instituto gubernamental, no, es que sí estamos, es personal médico, porque también creo que es importante tocar el tema de la calidad. O sea, la calidad en la prestación de servicio no solamente es que el usuario esté satisfecho, también el personal de salud esté satisfecho en la prestación. ¿Cómo? Pues que tenga todos los elementos técnicos que necesita para prestar un servicio, ¿no? Que sirva su equipo de tomografía, que sirva la resonancia, que sirvan todos los elementos que ellos requieren para que el paciente tenga una calidad y un diagnóstico efectivo. Entonces, en el tema de la transparencia, creo que en nuestro país todavía le queda de ver a mucho a sus ciudadanos y también a sus prestadores de servicios. Y no es coincidente con la política y lo que se escucha en el discurso con lo que realmente se vive. En México llegamos a ver ya calles paradas por padres de niños con cáncer porque no cumplen, no tienen su tratamiento. Estamos en la situación que para el VIH, siendo las de la apertura, no solo su atención, sino su medicación. Encontramos ya a los pacientes, por ejemplo, con problemas de salud mental, en movimientos donde dicen no tenemos la medicación, no tenemos la prestación de servicios. Entonces, es importante la generación de sistemas íntegros, confiables, no solo para las instituciones, sino también para la sociedad y que sean entonces, la verdad es que coincido con Ruth con respecto a lo que viven, ¿no? Y por ejemplo, yo diría en el caso de México, todavía le debemos mucho, ¿no? Hablando de la medicina intercultural, a nuestras poblaciones indígenas, ¿no? Que de alguna manera son cabezan desafortunadamente las tasas de mortalidad y la razón de muerte materna en nuestro país. Muchas gracias.
Gracias, Doctora Monica. Thank you, Dr. Monica. Summarizing, people, we're running a little bit over. We're going to have final considerations and then audience questions. Summarizing what Dr. Monica just said, in Mexico, we have a grantee central institution that supports the privacy and rights to information laws in Mexico. Unfortunately, there's a great disparity in between what the federal law and the state law applies. So the biggest challenge in Mexico regarding this is that we need to integrate federal and state laws to provide uniform access to the rights to privacy laws in Mexico, but also making sure we're integrating vulnerable communities such as Native communities in Mexico to the system, ensuring that they understand their rights, but also giving them the right means to access the system and enable them to be active participants in the rights to information and privacy laws in Mexico. Now, just moving on to finally, Dr. Faith, do you have any considerations regarding transparency and rights to privacy laws with healthcare in Nigeria? Dr. Faith Momo, you're in mute. You're muted, Dr. Faith.
Establish clear and comprehensive policies and guidelines that outline how patients' information will be collected, used, and shared. These policies should adhere to privacy laws and regulations, while still allowing for necessary transparency in reporting and communication. There is need for that. And we have to obtain informed consent from patients before sharing their medical information for transparency purposes. Patients should understand what information will be disclosed, how it will be used, and who will have access to it. When sharing data for transparency, ensure that personally identifiable information is removed or anonymized to protect patients' privacy. This reduces the risk of data breaches and unauthorized access. So there is need for that. Thank you.
Thank you so much. We have here in the room as well the nurse Rumbetsai Primrose from Zimbabwe. Who we're bringing up to the conversation right now. She had some technical issues and unfortunately arrived a little bit late. But Rumbetsai, if you would like to introduce yourself and would you kindly share your perspective on accountability and also transparency and rights to information in Zimbabwe? Hello, welcome.
Hello, how are you?
Good, good. Would you kindly introduce yourself to the panel, please?
Okay, my name is Rumbidzai Primrose Chikwavaire from Zimbabwe, and I'm a primary care nurse. I work at a rural clinic in Goromonze, just a few kilometers from our capital city, Harare. I work at a rural clinic. And I've joined the youth sector from 2006. And I have been stationed at the same youth center, and I've seen it grow from a 3-roomed clinic to a much bigger and better institution with the construction of a labor ward, postnatal care, consultation, counseling, and testing rooms, as well as medicine room and a dispensing room. Thank you.
Thank you so much. And could you briefly share your perspective on accountability in the health sector in Zimbabwe?
I beg your pardon?
Would you kindly share your perspective on the issue of accountability in the Zimbabwe healthcare sector?
Okay. I think over the years, I've seen a lot of positive changes in the approach to disease management. For example, TB and malaria treatment, whereby patients are taking fewer tablets to treat these ailments, as well as stigmatization is a thing of the past as far as HIV and AIDS is concerned. And we are registering few home deliveries and maternal deaths, secondary to health talks and village health workers who assist in the community by doing monitoring and evaluation. Thank you.
So much. We're gonna do final considerations now. Anna, if you would like to start, what do you see the common threads in the conversations that we were having right now? And what are your considerations for strengthening accountability based on the conversation that we just had between all the participants, all the panelists, I'm sorry.
Well, common threads are trust, clearly, transparency, accountability, and how do we strengthen that? Communication. Communication is at the center of everything. Yes,
I think communication has been clearly the relationship, the trust, communication, and relationship between patients, healthcare providers, and the general infrastructure. I'm gonna go to Dr. Monica now. Doctor Monica, entrando en las consideraciones finales, ¿cuáles crean que sean los temas comunes que hemos visto en esta conversación y cómo se atiende en el sentido de el desarrollo del sector?
Pues creo que hay muchas cosas que se tienen todavía que resolver, como lo comenté de manera anterior, y coincido mucho con el comentario de Ana. Tenemos que seguir trabajando en consolidar primero la satisfacción del usuario, segundo, la transparencia en la adquisición de los servicios para la infraestructura, medicación, en general, para la atención médico-preventiva, la implementación de tecnologías que de alguna manera impacten. Y yo creo que lo más importante que también comentó Fight hace un momento es la parte de darle el valor que requiere la prestación del usuario, ¿no? A través de la integración formal de los consentimientos informados en la prestación de servicios de salud. Creo que son como los pendientes a realizar y pues obvio, ¿no? A seguir trabajando en atacar la mortalidad materna, la violencia de género, que es algo que nos sigue lastimando a todos los continentes, la parte de la prevención de la mortalidad infantil y obvio la parte de las enfermedades emergentes como el la situación COVID, que de alguna manera pues han fracturado y debilitado los sistemas de salud en el mundo.
So much paraphrasing. The summarizing, Dr. Monica thinks that between the common threads, the key essence to improving healthcare sector is improving systems infrastructure between all the parties involved, as well as addressing the improvement of those systems to tackle important topics that are still lagging behind, at least in Latin America, which is gender-based violence, maternal mortality, and infantile mortality as well. Going to Faith Momo now. Please, as a final consideration, based on the common threads that we touched on this conversation, can you think what do you need? What do we need to do to improve in the healthcare sector?
Yes, we need to be accountable. The common trends we have is accountability, trust, and confidence. And that is what we need. And we need to be bold to stand and say no to all the negative things that is happening in the health sector. I know that a single person cannot stand and say no to it, but we have to start for somewhere. Let us start from somewhere. We started it and it's going smoothly. Let us continue with it. Let us not be afraid. Let us stand and believe in what we are doing. We'll reach the goal. Thank you.
Thank you so much, Faith. Finally, Robitsa, if you would like to give us some considerations on your perspective based on the threads of accountability and transparency, what do you think do we need to do to improve in the healthcare sector?
Okay, I think we need to improve in some of the things like setting accountability standards and protocols for healthcare workers. I think that will help us. And also there's need for proper supervision, support and monitoring frameworks that will support the transparency in the health sector. And I think there's need for a laying out of clear guidelines and framework, as well as the accountability trainings, such that everyone will be versed in accountability and will try to practice accountability in the health sector. The health sector is it's a sector that needs that works with the health, the life of people. So it needs accountability in much of everything that we do. So I believe that if you do good to anyone, you have done it to yourself. Thank you.
Thank you so much. We appreciate all your participation. We're gonna have a brief round of questions right now. Let's keep it brief. Alawi, would you like to coordinate this part of the questions, please, just to grab a question and ask it directly to the panelists?
Sure. So our first question could be, if it's from Manzoor from Bangladesh. So do you think to ensure healthcare with accountability, do you think that we are allowing our government to be reluctant in appointing people who are not medically qualified or have no medical background?
To our panelists, who would like to answer this question?
So I typed an answer to that one already. So I'll talk. It doesn't matter who you appoint if they have no integrity. We had during COVID, we had a doctor as our minister of health, and he was embroiled in a scandal because he granted some COVID contracts to his son or something like that. So then he resigned. So it doesn't matter. It doesn't have to be somebody who's medical in a position of political power. It has to be somebody who understands what they're doing and acts with integrity and puts the needs of the people first and has good advisors.
So much. Alawi, next question.
Yeah, sure. That's the other questions are, yeah, so if anybody has any more questions, feel free to put it in the chat. There are comments. I can reflect upon the comments. However, if you are interested in asking a question, please put it in the chat. But that's about it.
We have a question here. How would healthcare service providers be held accountable when there is a clause that prevents them in their profession? That's a good question. It's a very challenging question, actually. How would healthcare service providers be held accountable when there is a clause that prevents them in their profession? I think Faith Momo, this is a question specifically related to Nigeria. It's asked by Mr. Matthew Oladele. He's commenting here. When talking about maternal perinatal death surveillance response in Nigeria and developing countries, the errors from the health workers are not taken seriously, but they would trace the cause of the death towards domestic occurrences that must have happened. It apparently feeds into a clause of no name, no blame that is becoming quite challenging to deal with. What do you think can be done to improve the situation?
Thank you for that. What is needed is, for instance, in my place, we used to have a lot of mortality rate before. Pregnant mothers, children dying because of poverty. Poverty level is high. Then the children are dying because no money to take them to the hospital. The women are dying in the village. Nothing is moving well for them. So when the body came up, NGO, those are the one helping now. Sponsored by World Bank. They are the one helping so many today. The rates people are dying is no longer the way it used to be. The rate children are dying is no longer the way it used to be. It has improved. So for us to control this, is to fix the right people in the right position. Not because of politics, you will come and fix your brother, fix your sister. Those people will come, they'll eat what they want to, they'll do whatever they want to like and go away because they're looking for the money. They're not looking for lives. They don't care. So the only thing is to put those that have integrity. Like the way the doctor said the doctor that spoke, said that the person with integrity is supposed to be placed in the right position. And somebody, hello?
We hear you, go on.
A man of integrity is supposed to be placed in the right position to do the work. Somebody that will not look at the money, because a lot of people are looking at the money today. Someone that will not look at the money and concentrate on the life of people is the right person to be placed, not to place people anyhow, because that is what is happening in our place. Thank you.
Thank you so much. Mr. Ibrahim, I see your comment in the chat, please. I'll refer everybody to it. If there's no specific question, I'm going to ask you to refrain. If you do have a question, please put it in the chat.
Yes, good evening, everyone. Honestly, there are issues that I want to also bring to our not with regard to things that are happening in Nigeria pertaining to the health sector. What I observed was that the first issue, I want to also support what you said. The first issue where we need to have a kind of put more focus on is on the issue of budgeting. The issue of Nigeria's health sector should be seen both from the public angle and also from the private angle. From the public angle, our National Assembly, it has been a tradition that anytime they prepare budget, there is what they call budget padding. A chunk amount of money will be placed in agencies that are handling health sectors in the name of some activities which everybody knew nothing will be done, that money will end up in the pockets of politicians. And that kind of money used to be the first money that they used to take from the budget in the first quarter of the year. In case the money is not enough to fund the budget, it's not their business, they don't care. Secondly, you find a situation whereby doctors in public hospitals have their private hospitals, they have their private diagnostic centers, they have their private pharmacies, and when they come to make prescription, they prescribe things that they have in their pharmacies or tests that are in their laboratories. And if you don't go there and do the test, or you don't buy medicine from their place, they hardly give you attention. And sometimes they even have their private hospitals where they are working for government. And when issues escalate beyond the ability of the hospital, they're managing, which they deliberately sometimes mishandle, they will now refer you to the hospital where they can charge you at their own rate. And again, you find a
You're muted. That's okay.
Hello, can you hear me? You find a situation whereby sometimes money that's budgeted for building hospitals in rural areas or providing medication in rural areas, they will end up in somebody's pocket.
Sir,
And you find the
I'm sorry, sir.
maternal death.
I'm going to have to interrupt you. If there is a question, please ask it. If not, refrain from direct comments. This is a questions moment, and we have a question on the chat. If there is topic for direct discussion, please do so in the chat, but we're opening the mic for questions only.
So the question I want to raise is that, is there any possibility whereby there will be close monitoring of the budget from the point of preparation of budget to the point of implementation, where the end users will justify, yes, they've gotten the services from the money budgeted for them with regard to the health sector?
Thank you so much for your question. I think this is directly to Faith Momo.
Thank you. Yes, it can happen if the leaders allow that to happen. Because we have
I think we're having a little bit of technical issue here. Okay, Ala, we're moving on. While she comes back, can you address the last question in the chat, please?
Sure. So the last question is, what kind of strategies and mechanisms can be applied in Balochistan, Pakistan to renounce the ill practices by medical doctors? For example, the most common practice in Balochistan is the prescription of medicine to patients by doctors for their own personal interest. So just to summarize, there's an issue about doctors prescribing due to their own personal interest. And another question specifically in the South Africa context is, how does load shedding affect the healthcare institutions? So these are the two last questions that we have today.
Dr. Anna, if you want to address the load shedding first, please.
Then Musa. Oh, sorry.
So load shedding is a big problem. The specific facilities where I was working, we had a generator, but that obviously consumes a lot of diesel. So that cuts further into the health budget. There has been a plan or a proposal made to, specifically in the Western Cape, which is the province that I work in, to put backup generating power into all health facilities in this province. So that will be battery powered backup generators. It's more important in facilities where there's pharmacies. Not all facilities have pharmacies, but where there's facilities that have pharmacies that require medicine to be kept cold. Because then if there's load shedding, obviously the fridges will turn off, and the medicine won't be cold. We're also, I mean, it's very interesting to hear from Dr. Monica about the telemedicine, because here where I am, not everybody actually has a computer or a telephone in their room. So it's a problem. For example, if patients come into a facility and they don't have their clinic card, so you don't know what their folder number is and you can't find their folder. But if they have their clinic card, you don't actually need a computer to be able to find their folder. Yeah, so it does have an impact, and it also has an impact, like, for example, in the one facility that I worked in, where the record room was, there was no light, and there was no windows. So during load shedding, people had to use their cell phone torches to look for folders. But as South Africans, we're resilient and we find ways to work around. Yeah, so that's what we do.
Quite the challenge, it seems, from load shedding. I think it presents its
Yeah.
unique problems to the sector.
Yeah.
Thank you so much, Dr. Anna. Wrapping up, unfortunately, people, we are running out of time. I'm just gonna give the chance to Faith Momo to reply to the question that she was asked to before she had technical issues. Faith Momo, please take it away. What's the question relating budget? You're on mute.
Yes. Concerning the monitoring of the budgets, I said earlier that we have a lot of bodies that are fighting corruption in Nigeria. If they can allow those people to do their work, when doing the budget, let them include the personnel, those that have integrity, because there are some bodies that are fighting corruption and there are some corrupt personnel among them. So they should look into it very well and select those that have integrity to do the work, to follow those that are doing the budget from the beginning down to the grassroots. And with that, I know that everything will be okay. There will be a good result at the end of the day. Thank you.
Thank you so much, Faith. Everyone, thank you. I think we're seeing common threads here, which is really interesting, not only thematically, but also regionally, about the main challenges that we face in the health sector to address accountability, transparency, and integrity in all the parties. And a couple of them are especially focusing on keeping consistent trust between the communities involved, but also transparency in the systems that feed the information between the parties, meaning the patients and the medical practitioners, but as well as the institutional relationships between all the parties, and also medical care sector, those transparency mechanisms are there to benefit as well traditionally marginalized communities and address the topics that matter to them. We've seen many instances, I'm sure, in our countries and regions about gender-based violence, and the medical issues that go with them, which is obstetric violence, often not, which is shameful that it's still going on in the 21st century. But I think that also leaves us with a lot of work to do and a lot of reflection. I want to thank all our panelists for this beautiful discussion. I feel like we've all learned a lot. Unfortunately, we couldn't fit all the questions because of time constrictions, but please direct questions via chat or email to us, and we'll be gladly to forward them to the to our panelists, and then provide you with the answers as soon as we can. Thank you so much again for participating in this panel. We gladly thank you, and we're looking forward to the next one, to having you all on the next one. Thank you so much.
Thank you. You're welcome.
Thank you.